Next section up is burns for adult and pediatric patients. We have changed a little bit of the fluid administration rates. What burn centers have found is that we've probably over-resuscitated patients with fluid. So for advanced EMTs or paramedics, in the setting of transport time less than an hour, give fluids at a rate of 500 mLs per hour. The transport time is greater than 1 hour. Then use the Parkland formula, 1 to 2 milligrams per kilogram for each percentage of body part burned, divided by 8, thus giving you your hourly fluid administration rate over the first 8 hours. We also ask that you use warmed IV fluids, if at all possible, to prevent any hypothermia in these patients. The pediatric burn is a little bit different just because of the fluid administration rates. So for patients less than 2 years of age, 100 mLs per hour at max. 2 to 5 years of age, 125 mLs per hour max. And then for 5 to 15 years of age, 250 mLs per hour max. Those are all in the setting of transport time less than an hour. If the transport time is greater than an hour, fall back to the Parkland formula, as we had spoken about before.
The only thing I would add for burns, please be very vigilant about documenting and or communicating how much fluid has been given to these patients pre-hospitally. Part of the problems our burn centers are seeing is that pre-hospital fluid administration volume isn't being documented, so it's not being captured when they're trying to calculate how much fluid a patient has received or needs to receive. So next is drowning, submersion injuries. A couple of changes in this protocol. The problem that we're finding is, when do we resuscitate and how long do we resuscitate a submersion injury? And a lot of times this is based on cold water versus warm water drowning. And what we're finding is the evidence really just isn't that great. It's all case study based. Before it was basically our expert consensus was based on just kind of what the medical control board felt would be best practice. Since then, there has been another expert consensus paper published in 2010, and we decided to use that because we figured it's better than the evidence that we've had as a group of physicians around the state. So basically, if the water temperature is estimated to be less than 43 degrees and the patient is submerged for less than 90 minutes, you can do full resuscitation. Greater than 90 minutes, you can consider not initiating resuscitation or terminating efforts. If the water temperature is greater than 43 degrees and the patient is submerged for less than 30 minutes, full resuscitation. Greater than 30 minutes, consider again not initiating resuscitation efforts or terminating efforts. I wish we had something a little more practical and a little simpler, but it's really the best evidence we have at this point. So hopefully some more data will evolve and we'll have better answers in the next couple of years.
In the meantime, you should all practice on estimating 43 degrees.
Also, just to note, for the AEMTs, the CPAP has been moved up to their level as well. The next protocols are eye and dental protocol. No changes there. A couple of additions. We've just included under irrigation of the eyes to include pepper spray, if a person's been pepper sprayed. And then under the extended care, if somebody has an evolved tooth that you can, and you're going to be delayed more than 4 hours, you can try and reinsert that tooth back into the socket. So that's that. Musculoskeletal is a brand new protocol. Who wants to talk about that? All right, I will. So, for the musculoskeletal injuries, the main bulk of it was in the routine patient care for wound care and splinting. We've separated that out. And then under the extended care, we've added some additional bullets. The first being for impaled objects, that they can be removed if the object is in a location where removing it is not going to cause significant hemorrhage. And also just consider like an extrication of an impaled object every time you move or step that object's moving and causing further damage. So that bullet has been added. Again, you'll have to have taken the advanced training or the nationally certified training in this, and there's more discussion on it in that training. Reduction of dislocated patellas, shoulders, and digits are also included. And finally, at the paramedic level, we have antibiotic administration.
Please, if you do wind up giving antibiotics, make sure that the patient does not have any allergies. Ancef is probably the recommended antibiotic. Adult dosing is simply 1 gram IV.
Ceftriaxone.
Ceftriaxone, pardon me. Okay. Ceftriaxone is the recommended antibiotic of choice, 1 gram IV. There's a lot of talk about cross-reactivity of cephalosporins with penicillins. So if the patient tells you they have a penicillin allergy, unless they truly had an anaphylactic reaction to penicillin, we typically go ahead and give cephalosporins any case. So that's that.
That's it. Thoracic injuries is no change. Traumatic brain injury. Only change there is we had Haldol in there, and Haldol is a medication for psychotic patients, not brain injured patients. So we've removed that.
If the stick with the benzodiazepines, if you have a patient who's combative with a traumatic brain injury, dazolam is preferred if you have that, but the Haldol is not recommended for that.
All right, the next section of the protocols is our procedures section, and we have airway procedures and then other medical procedures. In the airway procedures, there really wasn't a lot of changes. One thing we did do was we separated out the supraglottic airways, so we now have a procedure for the combi tube, the King, and the LMA, and we added CPAP. One note, though, we might want to take just a minute to talk about is under the nasal and oral intubation, we've added post-intubation care for sedation, and where we've added midazolam, lorazepam, and fentanyl to those protocols.
Yep.
And then under just our regular or medical procedures, we've added the 12-lead acquisition. We've added quantitative waveform capnography, a taser, and a ventilator procedures. So I think we'll probably look at tasers for a second.
Do you want to talk about any other ones? 12 lead? Nothing? I'm sure we'll start off.
Well, the 12 leads, this is what has been in the scope of practice modules for years that people have been training with. We've just kind of, trying to be consistent, put it in the protocols.
Noted. Spinal immobilization protocol is essentially unchanged.
Yep. I guess we should take a minute and talk about the IO protocol, though. Again, at the beginning we talked about the EMTI versus the AEMT, and the AEMT can use the IO in pediatric patients. Additionally, they can give the lidocaine before any infusions. And so if you turn to, it's under the procedures number 6, it says prior to IO syringe bolus or continuous infusion, ensure the patient has no allergies or sensitivity to lidocaine, and slowly administer the lidocaine through the EZ-IO catheter and allow it to set for a good 5 minutes, 2 to 5 minutes. And I like to think about when I've been to the dentist and had Novocaine, and the dentist gives me my Novocaine shot, and then he leaves the room for a few minutes, and then he comes back. You want to wait for that, get that anesthetic effect before pushing your fluids.
Something else I would add to the IO, we generally have this in there as if you can't obtain peripheral IV access on a patient who needs immediate life-saving intervention, you can move to the IO. We did, however, put in there that you consider using this device as a primary access device during your cardiac arrest patients. It's often easier if you're working down at the legs as opposed to having to interrupt chest compressions or have access to the patient. So it is acceptable in cardiac arrest as a primary vascular device.
Quantitative waveform capnography. Jim, you wrote this one.
Yeah, so this is, again, a lot of services are carrying entitled CO2 detectors. We want to kind of give a little bit of education and sort of the procedure involved in this. So take a look at it. It's going to give some good information on when to use it. It's good. It's required to check confirmation of endotracheal tube placement at the paramedic level. It's really the gold standard in terms of confirming your endotracheal tube is placed correctly. And then it's also helpful if you have it available to you if you place a supraglottic airway to put on there. It's not required equipment for that, but it's a helpful device to use. And if you want to take a look at somebody's respiratory status, if they have ultramental status, if you can attach it to a bag valve mask as well if you're ventilating a patient to kind of look at the numbers. There's a lot of good uses for this device, and the more you practice with it, the better you'll get. So take a look at it at that procedure.
Yep, I think it gives you a lot of good information and helps substantially with airway management. Without a doubt, good thing.
The restraints procedure was pulled out of the behavioral emergencies and made into its separate procedure here.
And we did this in conjunction with law enforcement.
We have a new, when we get into our policies, of police custody policy that we'll talk about. And if the patient needs to be restrained, then there's a link to come back to this protocol. And this includes both physically restraining a patient and, if necessary, chemically restraining them pursuant to the behavioral protocol.
And what I would add to that, if you're going to be physically restraining a patient and they're still combative and struggling, these are patients that are generally going to need chemical restraint as well. If you do have to physically restrain somebody, obviously your safety is going to be paramount. But if they are restrained and they're struggling against those restraints, that can cause additional problems such as exacerbating excited agitated delirium, as well as maybe causing rhabdomyolysis, some muscle breakdown for these patients. So chemical restraint is appropriate if you need it, if they're still struggling in restraints after they've been physically restrained.
But please keep in mind when you're restraining the patient, try and consider, is there some underlying medical process that's reversible that's causing this? Is it hypoxia? Is it hypoglycemia? Drug intoxication, agitated delirium, head injuries, things of that sort. But the primary two to keep in mind that you could immediately do something about and affect change: hypoxia and hypoglycemia. Narcotic overdose, administration of Narcan may be helpful as well.